Thank you so much, and sorry for the little delay, but just want to thank everyone for joining us. I'm Kate Trams, and this is our Essential Substance Abuse Skills webinar series. And today, Steve Steiny is going to be presenting the third installment of the clinical evaluation, which is treatment planning. This training series is brought to you by the National American Indian and Alaska Native Addiction Technology Transfer Center. We are part of the ATTC network, which also includes 10 regional centers, 5 international centers, a network coordinating office, and the National Hispanic and Latino ATTC. In the next couple of days, we will send out a follow-up email to everyone who attended, which will include a link to the recording, handouts of the slides, and a CEU request form. Our center is a NADAC certified educational provider, and we'd be happy to provide you with CEUs for a $15 fee. Immediately following today's webinar, you will be redirected to our GIPR evaluation. This survey takes just a few minutes to complete and asks about your satisfaction with the event. This feedback is critical to our future work, and we value your opinion and would greatly appreciate your time in sharing your thoughts with us. You will be muted for the duration of this webinar, so please use the chat pod to share your questions and comments, and we'll address your questions at appropriate points during the presentation. Today we have Steve Steiny speaking for us. Steve is our program manager for the tribal, I'm sorry, I have the wrong thing in here. Steve is the program manager for our Addiction Technology Transfer Center project and has been an alcohol and drug counselor since 1997. He has worked in behavioral health services in the nonprofit sector for the past 23 years and has been in recovery for over 31 years and has committed his life and his profession to helping others in the recovery process. So I want to thank Steve so much for presenting for us today. He has a lot of experience and knowledge in this area, so I'm going to pass things over to him now. Thank you, Steve.
Okay, thank you, Kate. As I said earlier, well, good morning to everyone, and appreciate you all being on today. I see a few familiar names from our last session in November, and as I said earlier, this is part 3 of the series related to evaluation. Screening was October, and assessment was in November. And now we will be going over the treatment planning portion of the evaluation process. Got a lot of slides to cover this morning. I'm hoping everyone can hear me okay. I see Amelia and Nicola can hear and see me. And I think Stephen's asking me to speak a little louder. I am working on having a headset next time, but we couldn't get it to go. So hopefully I'll be able to project a little bit more. And can you hear me okay now, Stephen? Perfect. Okay. So like I said, we have a lot to cover today. I'm hoping that we have a chance to have a little bit of time at the end to do some questions. Or if you want to type in some questions as we're going, I'll do my best to try and swing back to those and talk. We can talk about those. Kate, are you still there?
Yes, I'm here, Steve.
Yeah, I just seems like I've lost my notes section. I don't know if oh, there, now it's back. Okay, got it. I must have hit a button or something. Anyway, let's see if we can't move through the slides. And if you have some questions as we're going through and they come up, feel free to type them in, and Kate and I will try and field some of those as we go or at the end. As I said, we're gonna go over some fundamental components of treatment planning as part of the clinical evaluation process. You can see some of our goals here. We'll try and cover today. Define treatment planning, understand the correlation between assessment and treatment planning, an overview of the treatment planning process. I'll also refer to the treatment plan as a healing plan. It's a term that I picked up when we were training down in Pine Ridge last month, and I really enjoy that concept of a healing plan. So I may use that synonymously with the term treatment plan. Treatment plan history and an introduction to treatment planning using the MATRS model. I also will refer to this as the SMART model. They're essentially the same thing. We'll talk about those. We'll also look at progress notes and how those play into the process of documentation and collaborating with your patient. So before we get going, I just want to again thank everyone for being on the call. And I want to just take a couple of minutes before we get going to just clear our minds, and I want to just say a short prayer before we get started. Okay. What is treatment planning? What is a treatment plan? So this first portion of our discussion today, we're just going to really look at that. And I'm going to assume that many of you have done some treatment planning or created a healing plan with your patients. And I'm going to assume as well that many of you are working in the field currently and are familiar with some of the components for what comprises a treatment plan or a healing plan. Some of this may be a review, but let's go through it together. What is a treatment plan? It is really a result of a collaborative process between the patient and the counselor or clinician. Counselor and the patient develop goals and identify strategies or interventions for achieving said goals. These could be in the form of action steps or some type of means by which the goal would be achieved. Just thoughts on treatment planning. The treatment plan, I want you to think of it really as a living document. This will change during the course of the patient's treatment process or involvement. The continuing care plan and discussion really should begin with the patient almost immediately, and then progress as the treatment process progresses post-admission. A patient's recovery plan truly begins the day they complete their primary treatment stay. And by that, I really mean they may have planned and coordinated with you and other members of the staff, but really they put that into action the day that they complete their primary treatment care and move into continuing care or complete or a discharge. The more we involve our patients in the treatment planning process, the more meaning and purpose it will have to them. And I'll say that a few more times today as we go through these slides. Is everyone hearing me okay still? I'm going to try and move this in a little closer here. I don't want to get you guys too close to me. That might scare some of you off the call. How's the volume now? I'll just keep projecting. Kate's office is right next to me. She can probably hear me right through the walls if I speak this loud. Treatment plans incorporate information gathered from the assessment. This could be the result of the ASI tool or any other instruments that you're using to gather information. Remember, we've started with screening, and then we have done our assessment, and now we're in the portion of this continuum where we've gathered a lot of information, and we're now getting ready. The patient may have completed an intake or an admission, and we're getting ready to start to develop and formulate a healing plan. So this is really, it's based on why the patient's there, and we're using a lot of information, not just patient reports, but collateral information, historical information, and it may be information from other treatment facilities. It also could be information from a spiritual advisor, could be family, could be a probation officer, any number of resources. And it usually involves the presenting problem or the reason why the patient has come um, to your facility in the first place. Bridging the assessment with the treatment planning or the healing plan. This is really where you are taking taking the information you've obtained and interpret all the relevant assessment information that we've gathered, and then integrating and making an integrated treatment plan to address those substance use issues and any mental health issues concurrently throughout treatment if possible. Really, the things to keep in mind as well are to address any pressing needs or immediate concerns, evaluate patient motivation to address their substance use issues, identify any treatment goals and target behaviors, select interventions for achieving goals, choose measures to monitor outcomes of the goal setting. And we'll revisit that in a little bit as well. And then follow up and modify treatment planning as necessary. Remember, that treatment plan is a living document. It is going to change over time. If it's not changing and being adapted, then you are doing a disservice to the patient. Treatment planning. At a minimum, the treatment plan addresses the identified substance use disorders as well as issues related to the treatment progress, including could include relationships, employment, education, spirituality, health concerns, legal concerns, any number of things, housing, could be all kinds of things that could be incorporated into that treatment plan or that healing plan and the related goals. So let's look at, I want to sort of overlay this notion of developing treatment goals with this idea or concept of a patient's readiness to change. So the first step we'll sort of look at here is obtain and interpret all relevant assessment information. So the stage of change that the patient is in may drive and really influence the type of goals you develop with that patient together or collaboratively. It will influence this process and will influence perhaps the content as well that is involved in this assessment information. The role and importance of patient resources and barriers to their treatment engagement and the impact that the patient and family systems have on treatment decisions and outcomes must also be considered. And then other sources of assessment information as well should be considered. The impact of the family really, we need to keep that in mind. Treatment decisions and outcomes, there may be some cultural considerations as well based on the family and the community that the patient is engaged with. Number two, explain assessment findings to the patient and significant others involved in potential treatment. And this is important, making sure that the patient knows that the information that they're reviewing with you is protected, like any other service that they're receiving from you. It's confidential. This explaining and reviewing this may be important for you to effectively communicate that and know how the patient communicates. Factors affecting the patient's comprehension of the assessment findings. So it would be difficult to develop treatment goals if the patient does not understand portions of the assessment. For example, what their primary diagnosis is, what their concerns are related to their In this case, their alcohol or drug use, if it's in a treatment setting, substance use disorder treatment setting. And then the roles and expectations of others who are potentially involved in the treatment process, whether that be a spouse, an employer, or family members extended. Number 3, provide the patient and significant others with clarification and further information as needed. Again, using effective communication styles and methods to elicit feedback from others involved in this treatment process, especially if the family is involved and invested in their loved one's health and recovery. Number 4, examine treatment implications in collaboration with the patient and significant other or significant others. Again, we want to look at the broader picture here and looking at available treatment modalities, patient placement criteria, and any cost prohibitive or barriers associated with cost for services. The effectiveness of the various treatment models based on current research, and implications of various treatment alternatives, including no treatment. In other words, if there's no treatment involved, formal treatment recommendations involved, in the treatment planning or post-assessment planning may be something outside of the facility. It may involve a referral or some informal treatment interventions. 5, confirm the readiness of the patient and significant others to participate in treatment. Again, I'll reference the stages of change. If you're not familiar with those, I would suggest becoming familiar. It really is a way to gauge the patient's readiness to be involved in treatment and make lifestyle changes. There is a motivational process, motivational interviewing process that can take place, and there also the implementation of the stages of change model. Number 6, prioritize patient needs in the order they will be addressed. Treatment sequencing and the continuum of care should be considered. The hierarchy or prioritization of needs should be considered, and the interrelationship among patient needs and their issues at hand. Think about Maslow's hierarchy of needs. Think about safety and security, legal issues, any sort of functional impairment. There's a lot of factors to consider here. Is the patient seeking personal growth, or is this really something that they're mandated to do and engage and reflect on? Number 7, formulate mutually agreed upon measurable treatment outcome statements for each need. And again, this is the key here is mutual, and the key here is I think collaborating. The more we involve the patient in the development of their goals, the more meaning and purpose it will have for them moving forward. So the clinician having a good understanding of the patient's level of motivation as it relates to perhaps stages of change, treatment needs of diverse populations, and how to write measurable outcome statements. This can be tricky. Your agency, especially if you're in an agency where there is an electronic health record system, should have some templates or drop-down menus to help guide you in developing treatment plan goals, specific goals with measurable outcomes. Number 8, identify appropriate strategies for each outcome. And again, this can be tricky. Those of you that have some experience may have some goals and action steps that have served you well in the past with other patients with similar issues. And this may be something you can utilize based on your experience. But using intervention strategies, level of patient interest in making specific changes, and treatment issues with diverse populations. Yeah, someone's asking about equine therapy. I think yes, Marcita, I think that would be a perfect measurable realistic goal to include in a healing plan. Very important. So yes. 9, coordinate treatment activities and community resources. And again, I think this is pretty intuitive, but I think it's important to keep in mind and look at this broader picture as we move through and begin to develop some treatment goals within that patient's healing plan or treatment plan. Coordinate treatment activities and community resources with prioritized patient needs in a manner consistent with the patient's diagnosis and existing placement criteria. So making those goals connected to where the patient is at in their early recovery, as well as the other factors that have been revealed during the assessment process. Treatment modalities and community resources, contributions of other professionals, mutual help or self-help support groups, current placement criteria, which we will review towards the end of the presentation today regarding ASAM criteria. I want us to look at that and at least have an understanding of that, and the importance of the patient's racial and or ethnic culture, age, development level, gender, other life circumstances, all coordinating to the patient's needs. It's really looking at the whole patient. 10, develop with the patient a mutually acceptable plan of action and method for monitoring and evaluating progress. Short term is considered 1 year or less. Long term is a year or more, to give you sort of a timetable for goal setting. The relationship among problem statements, desired outcomes, and treatment strategies. Short and long term treatment planning and evaluation methodology. 11, inform patient of confidentiality rights, program procedures that safeguard them, and the expectations imposed by regulations. I think this is paramount, and it should be continually reinforced that the work you're doing with that patient in their treatment plan is protected just as any other document within their records. And again, using effective communication styles and also making available to them resources for legal consultation. Most agencies have access to a facility or organizational attorney as well. 12, reassess the treatment plan or the healing plan at regular intervals and when indicated, making the necessary adjustments. So evaluate treatment plan and stages of recovery, review and revise the treatment plan periodically. This may be connected to your individual session with the patient, or it could be done periodically outside of that time. I know in the past, we sometimes would spend one group session or 2 group sessions in an intensive outpatient group or a residential group, having as a group reviewing treatment goals and sharing some ideas and progress. So there are some ways to do that outside of the individual session as well, if the patient's comfortable with that and your agency supports such a process. But remember, the treatment plan is a living document, and revisiting any adaptations culturally should be considered at the beginning and throughout the treatment planning and revision process. Let's again look at treatment planning along this continuum. Let's continue to build on this. Again, the more we involve our patients in developing their healing plan, the greater meaning and purpose it will hold for them moving forward. Can't stress that enough. You must involve the patient in deciding what they want to do, if they want to do, what sort of changes they make, and what your role can be as you help navigate them through that process. Treatment plans can be meaningless and time-consuming, They can be ignored. They can be developed and then just simply never looked at again. And they can be the same plan for everyone, just with a different name on it. So it's very important. Treatment plan goals may look very different for a patient in an entry-level outpatient service compared to a patient in a 30 to 60 day residential program. A patient's age and gender, what substances they identify as their substance of use, cultural background, all of these factors will influence goals and action steps that a patient brings to the session. What other factors might influence planning goals, treatment planning goals? That's something to consider. For example, an extended outpatient a patient in extended outpatient may only review their treatment goals 1 or 2 times during their treatment involvement. If it's a short duration or a short psychoeducational program, they may not have a chance to really take a deep dive into their treatment goals. Whereas a patient in continuing care, for example, they may have some base goals that followed them from their primary care that they may review and revise throughout their continuing care involvement. That could be, over the course of a year or more. Other organizational considerations. Information requirements of funding entities and managed care. Is there duplication of information collected? Is technology used effectively? Now, with all of the paperless and electronic record keeping, this is something that is really important to keep in mind. And again, paperwork is documentation in treatment. Is there useful documentation in the treatment planning process? Again, I think the software or the format for your treatment planning in electronic form is really vital here to make this a meaningful and efficient process for all parties involved. The field of substance abuse treatment, early on, it was really sort of one program, very myopic view, sort of one size fits all. The goals were all very sort of program driven, kind of this template that didn't change. And it was this idea that the agency knows better. The agency knows what that would be best for the patient, essentially. Looks like Emery's asking a question. Can you define cultural-based approach when it comes to treatment planning? Well, I mean, I can use a real basic approach in talking with some of the native communities. It may be important for there to be in the treatment plan something specifically related to smudging or related to going into the NEPI, or there could be some other cultural factors that could be woven into the healing plan that are very culturally specific. I hope that makes sense. And someone mentioned the equine therapy too. That can be related to a culturally specific approach in certain native communities. So hope that answers your question as we're going, Emery. So this idea then of this one size fits all, these program-driven plans, this is how it used to be in the old days. That in-your-face kind of one size fits all, my way or the highway. Patient's needs are not important. The plans often included only standard program components, and there was little difference among treatment plans. Really, if you think about it, again, the old sort of 12-step or disease model approach really might have included many of these goals that were already in place before the patient even arrived. And many of these have been phased out as the field has evolved and has many treatment facilities have evolved. And there are going to be some that will still have a very strong connection to the 12-step recovery community and this 12-step Alcoholics Anonymous approach to recovery. I'm certainly not saying that doesn't have a time and a place, but I know that the field has evolved and broadened quite a bit. We know there are many pathways to recovery, and the goals should be reflective of that. Again, program-driven plans, they often only included services that were available at the facility and oftentimes did not include referrals to community services outside of the facility itself. And then the shift began to happen, and I think this shift parallels a lot of the changes and the evolution that's been happening in the substance abuse field in general. But we begin to see the emergence of individualized treatment plans, many options available, customizing and tailoring and individualizing these. This notion of a living document began to sort of emerge, that the treatment plan could change, the goals could change over time. And it's based on patient feedback and in his or her own words. I remember once I was doing a goal with an adolescent patient, and we were coming up with things, she was coming up with things she could do during the weekend. And she said, well, I'll just do some chilling and grilling. And I typed that into the plan, and then I had to make sure I knew what chilling and grilling was. But we came up with a plan for her to have a barbecue, have some friends over, and relax for a while, i.e. chilling and grilling. But using my point is it was really important for her to see that goal in her own words. And it had an impact, and I think I felt like that goal that had more meaning and purpose to her. Individualized plans developed to match patient problems and needs. To individualize a plan, what information is needed? That's a great question. What does a counselor need to discuss before developing a treatment plan? And there are a lot of factors that might be involved here. It could be the rapport you have. It could be the patient's level of readiness to change. There could be a number of factors influencing this. But I think there are some really good templates and treatment plan guides available out there, oftentimes built right into an EHR system. And like I said earlier, oftentimes an experienced therapist will have developed a menu or have an adjusted list of goals and action steps based on previous patients with similar issues. The experienced clinician can often share and mentor some of these strategies and goals with newer clinicians, but it really is about involving that patient and using the information you have gathered throughout, perhaps all the way through our continuum, from screening to assessment and now to treatment planning. To individualize the plan, what information is needed? Again, possible sources of information may include things like reports from their PO, could be using different assessment scales or screening results, collateral interviews. It could be examples of individualized treatment plans from previous patients where there's some similarity in issue or concern. And then feedback and discussion with supervisor or mentor about treatment planning or healing planning and what that looks like. This is an important concept as well, really in all the work we do, but in particular in the addictions field or in the substance use disorder work. We need to keep this biopsychosocial model in the forefront of our mind with almost everything we do. Because I think everybody listening today would agree with me to some extent that a patient's alcohol and drug use really is not the problem. A patient's alcohol and drug use is really not the problem. It's causing them problems, but it really is a symptom or an indicator. There's something else going on under this biopsychosocial umbrella that the patient has yet to find a healthier way to work through. They haven't found, they're trying to find meaning and purpose. It could be trauma, it could be a medical issue, a mental health issue, any number of things could be going on. I hope that makes sense. And yes, you're welcome, Marcita. I see a few others agreeing. If I could see all of you, I would hope I would see some heads nodding, perhaps. That's my next step, is to get all of you guys on my screen so I can see you all. I would feel more connected to you. So let's keep going. So biopsychosocial, the biopsychosocial model example. Just some things that you might consider. Does the patient have transportation? Can they access transportation? How close do they live to the facility? How available are substances, alcohol in the home or close by? These are all factors to consider as we look at this biopsychosocial perspective. If we look at the Addiction Severity Index, a tool that's, I think, used in the AccuCare system for a lot of the IHS facilities, problem domains in the biopsychosocial model. They're going to implement this, the biological, psychiatric, and family and social. These are all examples of biological, psychological, and sociological factors. Why make the effort? Well, if you make the effort and apply some of what we've been talking about, you'll have individualized, adaptable treatment plans or healing plans. It can lead to increased retention rates, which are shown to lead to improved outcomes and less recidivism. It empowers the clinician and the patient and focuses on the counseling session. A really good individualized treatment plan can be reviewed without really the patient or the clinician knowing that that's what they're doing. It provides the patient with an attainable framework from which to build measurable recovery goals. Especially early on, this is crucial. And I would rather have, in a good, solid healing plan, I would rather have 1, 2, maybe 3 really good goals that the patient has come up with a few attainable, realistic action steps that are measurable, and rather than a dozen goals that we would get lost in trying to review. So think quality over quantity when it comes to goal setting with your patient. Again, why make the effort? A good healing plan should fit the patient like a puzzle piece. It should fit them clearly, and it should be based on their input. And when we see this in the ASI, the items are used to fit the patient's services and interface them with what their needs are, at least theoretically. What's included in any treatment plan? That's a great question. Here's just some components to consider. And again, there's going to be exceptions to these. These are just some components that we would often see in some variation or form in any good healing plan. Problem statement. This could be information, based on that assessment that you had with the patient, their presenting problem. Goal statements, objectives, interventions. So what the patient will do and what the staff will do to assist. Treatment plan components would also be, again, based on the information gathered at the assessment. Goal statements are based on sort of the underlying problem or concerns, and reasonably, there's a reasonable sense that these can be achieved in the active treatment phase. Objectives are what the patient will do to achieve those, and the interventions are what your facility or what you may do to help assist them. There's always exceptions to this idea, but remaining alcohol and drug free, for example, abstinence. Many treatment centers are abstinence based for good reason. You have to protect other patients and the continuity of the programs involved, but there may be times where treatment goals don't involve complete abstinence. You may be in a position based on the patient's readiness and what you've gathered in the assessment that you would look at a harm reduction or a risk reduction approach to reduce their alcohol or drug use. I'm not saying that you condone their use, but you at least try and meet them where they're at. That would be an example of something perhaps truly meeting the patient where they're at. I hope that makes sense. Again, review components in a treatment plan. There they are. We've talked about those. Discharge plan components. We would want to see the patient's strengths being reflected there. What will help carry them through as they transition to a lower level of care or complete their services, and that the participants in planning are documented. So there's evidence that you and the patient worked on these and reviewed these throughout the treatment process. Considerations in writing healing plans. All problems can be identified and are included regardless of available agency services. So even if a patient has an issue that's beyond the scope of the agency, documenting this and making a referral or consulting with someone outside of the agency would be advised. Include all problems, whether deferred or addressed immediately. Each domain should be reviewed. A referral to outside resources is a valid approach to addressing a problem. Tips on writing problem statements. These really should be non-judgmental. I even was trained at one point when I was doing some solution-focused therapy. We wouldn't even use the word problem. We would use the word issue or concern. So even that can have an impact on how it's viewed. But not using jargon statements. We really don't say the patient's in denial anymore, or the patient is codependent. Those are sort of from that last generation of counseling. Now we would say the patient is in a pre-contemplative stage of change. They don't believe there's a problem, so they don't think that there's a need to change. And just using complete sentence structure and those kind of things. I want to talk a little bit about MATRS, or as I was trained, this format is also referred to as SMART. Essentially the same thing, just they've moved the letters around a little bit. So either SMART goals or MATRS goals. These would be measurable, obtainable, time limited, realistic, and specific. Anyone else use this format for goal development or SMART goals, or maybe there's some other formats that people have used to sort of guide you through this process? So looking at objectives and interventions, yeah, Amelia says SMART, so that's what I'm more familiar with as well, Amelia. Objectives and interventions. This first one is measurable. So objectives and interventions are measurable. Achievement is observable. Measurable indicators of patient progress that may include any of those number of components. Yeah, Haley says SMART goals as well. So maybe I'll add a little section on SMART goals. These are the same thing, you guys, just the letters are in a little different order. Objectives and interventions as far as being attainable. Objectives and interventions are attainable during active treatment phase, focused on improved functioning rather than cure. I don't even like the word cure. It's very very absolute and has a stigma attached to it. Identify goals attainable and level of care provided. I think that makes sense. And revise goals when patient moves from one level of care to the other. Again, that's intuitively, that makes a lot of sense. I would imagine a patient completing some early goals in their residential setting, and as they transition into an outpatient setting, their goals may change because they may have completed or attained some of those early goals. Time limited, focus on time, short-term, long-term objectives, and then these can be reviewed within a specific time period. And sometimes that's driven by level of care. Some licensure agencies require, for example, that goals be reviewed every 30 days, some every 7 days, and there's some looser qualifications depending on the state and the licensure requirements. Realistic, and again, I think this can be a little subjective, but I think it's important to help the patient guide their level of realistic components to their goal development, and that the progress is going to require some effort and some work from the patient as well as yourself. And specific, just making sure the goals are specific. I know it's easy to do some kind of vague, open-ended goals, but if you're following this protocol, the more specific, I think, the easier it is to meet some of the other components to this MATRS format. So just be as specific as you can. Don't have to go over the top with this, but you want to keep goals from being too vague. That makes sense just intuitively. So there's kind of an overview of that MATRS or SMART sort of format, and just sort of a way to kind of check to see if your goals meet those qualifications, or the patient's goals, I should say. Treatment planning or healing plan process review. So again, it's really derived from the assessment. It's derived from information and data collected from the patient during their assessment, screening, and overall evaluation. It identifies issues or concerns. It prioritizes them. The goals are really designed to help address some of those issues that have been a theme or come up in the assessment process. And then just remember that format, the MATRS or SMART format. 5 components of an effective treatment plan. And again, there's going to be some exceptions, and you may have a style or a strategy that doesn't fit exactly with this. I trust you, and I'm sure that you all have clinical experiences that will be similar to this as far as developing a healing plan with your patients. But I think having clear goals makes sure everyone is on the same page, and keeps both of you, the patient and the clinician, accountable to focus on what is necessary and pressing. It also helps your patient feel like therapy is something that is more esoteric, something they could describe to a spouse or a family member if they were trying to explain things they were working on. So keep that in mind. So 5 components to an effective treatment plan. Goals, I mean, obviously we've talked about that. Having those documented and written down. It'll also help sort of know when it's time to reduce level of care or have them complete treatment services. Active participation. Again, this is a nice way to evidence collaboration between clinician and patient. And it really it's a great way to open up discussion and really defines the role of the therapist and the clinician throughout the process. Support. Another aspect of treatment planning that is too often forgotten. It's not just what you and it's not just you and the patient against the world, but this is really the understanding that they're going to need support and other things outside of just that therapeutic dyad. And this is a great way to develop that and make sure that that is part of the thought process in the planning. I hope that makes sense. And then just be able to have outcomes and to be able to say, for the patient to say, well, this is what I achieved during my stay, or this is what I was able to work on and make progress on. And it's a great way to measure some outcomes from both the clinician's perspective, and it gives us a way to talk about that in very concrete ways. And then again, just showing client involvement or patient involvement. We know, and I've said, I sound like a broken record, but you're involving the patient throughout this process, so it's a great way to show that, to say these are the patient's goals. This patient, one of their strategies is to do some chilling and grilling on the weekends. Oh, yeah, Marcita, I think that's a good question. I kind of addressed that earlier. Having abstinence or sobriety as a treatment goal, I think it can be, but we're going to match that with where the patient is at. So if I have a patient that's mandated into intensive outpatient, and they are on paper and they're under obligation to the state, they may not be ready to remain alcohol and drug free, but we may have to look at that as a component in deciding whether abstinence should be a goal for them. One of the ways I would work around that, I think, would be to, oftentimes I did this with young adults or with youth, I would say we would amend their goal for abstinence by adding a specifier. Remain alcohol and drug free for 3 months and reevaluate this goal, something to that effect. So, or a month or whatever it is, and then have some action steps underneath how they would achieve that. But making it, not making it so long-term or so absolute. Does that hope that makes sense? But I think it's important to have abstinence as a goal, because oftentimes it's contractually expected or contextually expected, or the agency itself has that as an overriding expectation. The exception would be if I'm working with a self-referred patient who is there because they want to be, and rather than completely stop drinking, they would like to reduce their alcohol use. Then the goal is not complete abstinence, but rather cutting down or cutting back. Hope that makes sense. Let's look at documentation. Documentation, just looking at the progress note, I think this is important in the treatment planning process, and it's connected to that in many ways. I'm going to assume that many of you are well versed in this notion of utilizing a progress note to document your treatment planning and weaving that review, the goal review or the development into your progress note. There are a variety of formats. I was trained on the NAPT format, narrative assessment plan and time, but there's probably a dozen or so different progress note formats. And now I think with electronic health records, it's pretty easy to keep those notes connected to your treatment plan and have everything right at your fingertips. And again, just this notion of collaborative documentation. This is a concept that our agency, the clinic that I worked at for many years, started to implement the last 5 years that I was there. This is where you literally are using, writing the note with the patient at the end of the session with their direct input. Even sometimes turning the screen to them so they can see what you're writing. Doesn't work for every patient, but it's a great way to promote transparency and collaboration, and your note's done when the patient leaves. Something to consider. There's a lot of training and resources out there about collaborative documentation. Again, just some basic guidelines. We don't need to go over these too much. Again, we want to have, these this documentation sort of fit this idea even surrounding our goal development. But having those, using those formats, having things in the progress note and in your documentation meet these criteria. And again, your entry should be your professional assessment. There's a portion of that. In the NAPT, there's a portion where I'm writing an assessment portion. I may do the narrative and the plan with the patient and leave the assessment portion maybe a little more rudimentary or add something to it later if the patient might be upset by an assessment or a comment that I would make. So you have to be careful about collaborative documentation. Continued plan of action, so having next steps, and then being able to, as I said, do this collaboratively with the patient's direct feedback rather than post service. And again, it just describes good documentation will describe the changes you see, outcomes, observed behaviors, and progress towards goals and objectives. So just kind of, again, a quick overview of treatment planning, obtain and interpret all relevant assessment information. That's sort of the overriding theme here. The goals are derived from the information gathered, direct input from the patient. And that's reflected in really this notion or this process of treatment planning. So explain assessment findings, provide the patient with clarification, examining and looking at treatment implications, confirm the readiness of the patient to make changes, and prioritize the needs that the patient presents. Continuing, just formulate this sort of mutually agreed upon plan, identify strategies, coordinating with outside resources. Again, developing a plan that's mutually acceptable, both in action and methodology. Inform the patient that the document is safe and that the information they share is protected and confidential. And then just this idea, this living document, you're reassessing with the patient's involvement the progress they're making. I do want to spend a little time going over ASAM criterion. How many of you are familiar with ASAM? I see Nicola is saying, yes, Jim, yeah. So I see several people chiming in. There are times I know when making referrals within tribal agencies that ASAM criterion is not required, but we're moving towards that. I've been told that ASAM criterion will be required when making referrals and to support your diagnostic information. So, but it's something worth thinking about. If you can think of ASAM, which is, anybody know what ASAM stands for? I got to put some polling questions back in these PowerPoints. Anybody? ASAM. Wait, Jim's trying to get in there. American says, yes, Rochelle has got it. American Society of Addiction Medicine. So think of ASAM as a universal language that clinicians throughout the field can utilize to monitor and identify a patient's risks in these different life areas. I could call up somebody across the country and say, this patient is a 4A in risk rating 5 and they need residential placement. If they're familiar with ASAM, it's like having a universal language across the entire field. I hope that makes sense. So yeah, so American Society of Addiction Medicine, think about these criteria. They're not a standalone assessment tool. They are a supplement to help guide us and make responsible, appropriate recommendations based on patient need. So they couple with DSM-5, they couple with your assessment tool, and they can be woven in as a supplement to help guide you. And it adds some consistency and some objectivity to the process. It's clinically driven, not program driven. The criterion do not involve a prescribed length of stay, but promote a flexible continuum of care. If intensive outpatient is 6 weeks long, but my patient's ASAM criterion and their progress on their goals is achieved at week 3, then they complete intensive outpatient at week 3, and I transition them into a continuing care group. If that patient is struggling and continuing to have difficulty at the 6-week mark, I may extend them 2 weeks, and their intensive outpatient may be 8 weeks, but it's driven by the ASAM criterion and the information that we've gathered. It's not program driven. That's the direction the field is going, everybody. It includes informed consent, and outcomes are driven, and there's a clarification of medical necessity as well. Just the levels of care. I think everyone's probably familiar with these if you're working in any kind of clinical setting. We have an early intervention setting, outpatient, sort of, it could be anywhere from extended or introductory outpatient to intensive outpatient, partial hospitalization, residential or inpatient, and medically monitored intensive inpatient treatment, and so on up the line. And I don't think detoxification was included in there, but it certainly should have been. Looking at just briefly, we don't have enough time to really take a deep dive into ASAM. We spent a full day talking about ASAM down in Pine Ridge a couple weeks ago, and it's something that we can really, you can really sink your teeth into. And once you have it conceptually realized, it overlays beautifully with DSM-5 and the work that you're doing with patients, especially in an assessment or placement setting, but also in a continued stay setting and a discharge setting. But here are the 6 dimensions: acute intoxication and withdrawal, biomedical, emotional behavioral, readiness to change, relapse, continued use potential, and recovery or living environment. The severity, we've seen the severity in each dimension rated. I've seen it rated as mild, moderate, or severe, but I was really trained on a 0 to 4 risk rating scale. So that's something to consider no matter what format you're using to assign risk rating. For me, the 0 to 4, A or B, it's more measurable for me than using a mild, moderate, or severe risk rating format. Like I said, early intervention is a 0.5 level of care. Usually involves some of these things. and your ASAM criterion in this level of care are going to really be zeros, risk ratings of zeros or perhaps a 1, but in all likelihood, the patient will not meet diagnostic criterion for a substance use disorder, but may have risk factors that warrant an early intervention level of care. Level 1, this is generally, I think of this as an extended outpatient or an entry-level outpatient. There may be an educational component, but there may also be a therapeutic component. It could involve even as a step down, it could involve some medicated assisted treatment services, or it could be, like I said, an entry-level treatment experience for someone who is a low-level readiness to change or early in their stages of substance use. And that's just some of the therapies too that involved in that level of care. Level 1 outpatient. So again, we're going to look at those 6 dimensions. If you're familiar with these, this will make a little sense. If not, and you're still training and getting familiar, it's okay. But you would look at matching the level of care. You would want to see the level of care synonymous with the risk ratings assigned in each of those dimensions. It's a great way to cross-check information you've gathered in the early screening or assessment component as you're looking at placement or continued stay review and assigning a level of care. So in an outpatient, level 1 outpatient, I really, in that acute intoxication or withdrawal, I should see no signs or symptoms. It should be rated as a 0. Again, likely biomedical concerns would be stable or non-existent. And dimension 3, the emotional, cognitive, behavioral, there could be some things going on. There could be a formal mental health diagnosis that would warrant a risk rating, but it may not impact or impair their ability to engage in that low level of treatment care. Dimensions 4 and 5, again, if I'm looking at an entry-level outpatient setting or a step down, there's a likelihood in that readiness to change dimension that they are willing to comply or actively engaged in the treatment process, or there could be a level of ambivalence that would warrant a higher risk rating. Perhaps they're not recognizing their substance use completely as a problem, and there's that level of that sense of ambivalence there. They still may be appropriate for an outpatient level of care. And then dimension 5, you're assessing their relapse continued use potential. Again, think about how many times this will come up at the time of placement, continued stay, and at the completion of treatment. Relapse continued use potential is vital to help limit a relapse or avoid relapse during the treatment process. So assigning a risk rating, someone in an outpatient, level 1 outpatient, likelihood they will have a lower risk rating in this relapse continued use potential, but this could change over time, which would warrant what? It would warrant perhaps a higher level of care, or in some cases, a lower level of care. If their risk rating goes from elevated to reduced, that may be an indicator to help guide the clinician and their team to reducing the level of care and tell them that it's time for them to step down into a continuing care or perhaps from residential to an outpatient setting. I know that's a little convoluted. If we had more time, I would take a deeper dive into the ASAM criterion. There's a lot of information out there, and there are some trainings available. And yes, Angela, we can talk more about that. I can maybe help you find an ASAM training that would help this be more clear to you. Dimension 6, again, remember dimension 6 is recovery environment or living environment. And this really, at a level 1 or outpatient setting, I would suspect and anticipate there would be some passive support or full support of a person's recovery, thus warranting a low risk rating and supporting this level of outpatient care. In a higher level of outpatient, we may begin to see some of these dimensions, these life areas, these 6 dimensions. We may begin to see some of these risk ratings elevate, either at the time of placement or during the course of their treatment stay. Dimensions 1 and 2, it's not uncommon to have no acute intoxication or withdrawal, or any comorbid or coexisting medical condition that would interfere with the treatment process. Not uncommon. Dimension 3, again, I'm going to look at cognitive, behavioral, emotional functioning, whether or not there's a formal mental health diagnosis. If there is not, I may not assign a risk rating, but I will make notes and monitor that, or perhaps make a referral that a mental health evaluation be completed. Dimension 4, remember, is readiness to change. So at this level of care, there may be more need for structure, and there may be more need for repeated interventions. The patient may be resistant to engagement, and this could warrant a higher risk rating based on poor attendance, continued evidence of continued use while in services, and a variety of other factors that would increase their risk rating in this dimension 4, indicating that they are less likely or less ready to engage in treatment. Dimensions 5 and 6, from an intensive outpatient perspective, remember, intensive outpatient is an intermediate outpatient engagement compared to a lower level of care like an extended outpatient that is either entry level or some kind of step down. Dimension 5 and 6, now, again, dimension 5, remember, is relapse continued use potential. So we may see some higher risk ratings at this level of care. Patient continues to provide urine screens positive for cannabis. Patient continues to report periodic relapses between group sessions. This may warrant, we may begin to build a case for a higher level of care based on those ASAM risk ratings. And when I go to call to make that research with the insurance company, that individual on the phone may ask, what is their risk rating in dimension 5? It'll be really important for me to have that information and have a concept of what that means. And dimension 6, of course, we could see elevated levels here, elevated risk ratings here as well, because this is a recovery environment. It's oftentimes who, where, and how they're spending their time in the community. And again, this theme continues. Now, in a residential setting, what type of risk ratings do you think we would see, or that would warrant a residential placement? I'm doing an assessment. I complete my assessment tool. I complete my ASAM risk ratings, 0 to 4, 0 being no risk, 4 being severe risk. What kind of ASAM risk ratings are we going to likely see in a patient who we are making a case for referral or recommendation to residential? That would be a good polling question. Okay, we may have to make a polling question. What I would say is that in each of these dimensions, it would not be uncommon to see elevated risk ratings. Those of you that are familiar with the risk ratings and how they operate, if I have a patient present to me in a walk-in clinic who's blowing very elevated BACs, I will assess them with the nurse for admission to a detox or a 3.7 level of care. And I may say this patient has an elevated BAC, a history of seizures and withdrawal. I am going to give their dimension 1 risk rating a 4. And there are 2 subsets, a 4A or B. And this may be the foothold or that stepping stone that I have to base my recommendation for detox or subsequent residential placement. This theme would continue through Dimension 2, biomedical. They may have ongoing diabetes or an untreated illness that's been exacerbated by their use of alcohol or drugs. I would note that and make a risk rating that's according to that. Dimensions 3 and 4, cognitive behavioral. We may see significant impairment and impact on their cognitive behavioral emotional functioning. This would be reflected in an elevated risk rating. Dimension 4, readiness to change. It could be that the patient's readiness to change is relatively elevated. They may be, their risk rating may actually be lower here. They may be saying, I need help. I want help. I don't know how to get it. So I may, it's not uncommon to see someone coming into a residential setting with a risk rating of 1 or 2. Relapse continued use potential, Dimension 5, remember? How elevated is that going to be in a person entering or being considered for residential? We often see this as a 4A or B. And again, if we had more time, I'd give you those specific definitions for each risk rating. If you can get your hands on some risk rating material, I have some available too. If you'd like some, you email me and I'd be happy to send you an electronic copy that gives a very nice description and a really nice format that we used at my clinic that could easily be adopted into your electronic health record system. Or talk to your supervisor too. They may have plans already, or your administrators may already have plans in place to do this. So we would, and again, Dimension 6 for residential placement, I would see elevated numbers here often as well, elevated risk rating numbers. They are often in a toxic environment, not supportive of recovery. That would warrant a 3, a 4A or B. Just briefly, just wanted to look over withdrawal management. Withdrawal management has become really more relevant now with the opioid epidemic. Within ASAM, the withdrawal management has a separate section, an overview section correlated with each level of care. We don't have a lot of time to go into that, but it really ensures that the patient withdrawal is being managed appropriately, entering the substance use disorder treatment, and that it's appropriate to the level of care that they're engaged in. And again, this just sort of gives you some ideas along this continuum, intake, observation, which medications are being prescribed and administered, and then what is their plan to re-enter the community given their withdrawal potential and withdrawal history, particularly with medications related to opioid use disorder and management surrounding that opioid use disorder. Very important to make sure that the discharge services are organized and coordinated accordingly. If they're on Suboxone or methadone and taking a buprenorphine based medication, that's part of that step down and discharge plan. It also addresses licensing and certification requirements for prescribers and to make sure that the agency is able to provide appropriate medical withdrawal management. Alcohol, benzos, not managed properly can be life-threatening, as we all know. And opioid withdrawal can certainly be life disrupting and can complicate many other underlying factors. So just wanted to take a look and just give you kind of this snapshot. Again, ASAM risk ratings, as they're connected to this notion of assessment and treatment planning, will influence the type of goals you develop, the level of care the patient is directed to and placed in, and it acts as a supplement. ASAM risk ratings can assist the evaluator, you, in making consistent accurate, and objective decisions about the patient's level of care and related treatment services. Now, there's always exceptions, but I'm just giving you a quick snapshot. This was a general guideline I utilized when I was training new clinicians coming in and trying to wrap their minds around this idea of utilizing ASAM criteria. And Arlen's asking me about the length of time that a person should be on a Suboxone medication. And boy, that's a tough one, Arlen, because there are a lot of different factors there, from induction to completion. There's a range there, and we have to remember with the use of buprenorphine or Suboxone or naltrexone or methadone, it's not a standalone solution. There has to be other pro-social, pro-recovery, other support services in place. The Suboxone is not just take this and everything is fine. The Suboxone addresses immediately the opioid use imbalance. And remember, opioid use disorders are first and foremost a brain disorder. The Suboxone, or that medicated assisted treatment, allows for the patient to return to some level of functioning so that we can then start moving forward and gaining some sense of normalization and neurochemical balance and a return or restoration of some level of functioning. So how long that takes a person is going to be determined by numerous other factors involved in their case. So I would be remiss to say and give you a definite time. Yeah, Maria is making a good statement there. The patient benefit from having support in the emotional, psychological, and spiritual as well. Yes. Oh, I mean, the mind and body and spirit are so connected, and recovery is not just about not using substances or drinking. It's about healing the spirit, and that can take time. I can be clean and sober, and still my spirit can still be diminished, and my soul can still be wounded, and that takes time. The healing takes time. So I appreciate those comments. I do. Just to give you a quick snapshot, and then we'll see if we can do a couple questions. We have a few minutes left. Looking at the ASAM risk rating and level of care, how those two interface. If I was looking and had an assessment, and I would want to see if my level of care was consistent with the risk rating I've assigned. And let's say, for example, I was recommending extended outpatient for a patient. They maybe have an alcohol use disorder, mild, first DUI, they're 20 years old, they have completed the evaluation, I've assigned risk ratings. I would want to see risk ratings generally from 1 to 2. And there could be a 0 in there as well. 0s, 1s, and 2s for a level 1 extended outpatient service. And you can see what I'm trying to say is that, particularly with the higher levels of care, if I am trying to make a referral and defend my recommendation so that our agency will be reimbursed by managed care or by insurance or whoever, that I'm able to support my recommendation with an appropriate risk rating assigned and associated with that particular level of care being recommended. I hope that makes sense. If you were all here with me, I'm sure I'd see some heads nodding, but I'll just assume that this is making sense to some of you. And Arlen is saying, as far as ASAM risk ratings, I understand those change almost daily depending on what is going on in the patient's life. Yeah, it could. If you look at a detox setting, our nurses would do risk ratings daily because you'd have that much fluctuation. The risk ratings are reviewed periodically depending on the level of care. The higher level of care, the more often those risk ratings will be reviewed. They're usually reviewed in a staff setting, and they're usually exchanged. You would exchange and review those with your peers and colleagues to cross-check your risk ratings, especially early on as you're learning about them. But I would agree, Arlen. I think you'll see some change. You want to see some change. And there's nothing better than seeing a patient's risk ratings go from here and watch them go down as they engage and respond to treatment. What a great way to support and evidence that treatment is working. It's another way to supplement and show that a patient is responding, that a patient is recovering. People can and do recover from this illness. I've seen it. I've seen it kill many people too. But yeah, I appreciate your comment, Arlen. So I just wanted to give you guys this idea about the risk ratings and how they correlate to the level of care that you're recommending. If you're not doing this already, talk to your supervisor, talk to your colleagues. The risk ratings can be a wonderful tool to enhance what you're already doing. So I don't know if there's other questions. I think we're just about out of time. Anybody have any direct questions for me at this time? I see Rochelle is typing, and Arlen looks like she's typing. You're welcome. You're welcome, Maria. I appreciate that. Thank you. I wanted to let's just close this out with a moment, and I'd like to just say a couple of words to close this and to wish us all well as we move forward in our day and the rest of our week. Father of light, Mother of earth, Creator of all, thank you for guiding me today, bringing these participants to the webinar. And I would ask that you keep us in your light and guide us through the rest of our days and week. And I hope that everyone has a good holiday and is surrounded by people that love and care about them. Thank you, everybody. Have a great day. And if you have some other questions, be happy to answer those via email. And I'm happy to share some ASAN information as well.
Awesome.
Okay.
Thank you. Yes, thank you, Steve, and thank you, everybody. Yeah, it just was a really great time, and I'm glad we got to connect with all of you. We do have another webinar, just so you all know, this Wednesday. That's a part of our mental health series, and so email me if you haven't gotten that link to that one. But otherwise, we will be resuming our series on this in January, so we hope you will join us then. And with that, we'll close out. So thanks again so much, and happy holidays.